Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm excited today to be talking with Dr. Scott Conard, a family physician who is founder and president of Converging Health in the Dallas, Texas area. Dr. Conard, thanks so much for joining with me today.
My pleasure. It's great to be here.
So let's take you back. How did you get to you find your way to family medicine?
Well, so I am a second generation family doctor. My dad was a family doc down in Bradenton, Florida. And, I'd wake up in the morning and there'd be tomatoes or fresh chicken or something on the back porch where one of his patients had stopped by. And I thought, wow, that's really special. We'd go out, we'd meet his patients. He would make house calls. I'd go with him. And I just really saw what a special relationship family medicine docs had with their patients and what a huge difference they made in their life. So I went to medical school down in South Florida, and I was going to be a family doctor. I mean, I had really, good grades and stuff, and I'll never forget one of my professors saying, "But Scott, you could go into, plastic surgery or orthopedic surgery or cardiology, invasive cardiology. Why would you ever do that to yourself?" I remember thinking that is the weirdest damn question I've ever heard in my life. Like, what else? Why would anybody want to go do those things when you could be a family doc?
Cool. So you went to medical school and then we're off to residency.
Yeah, I came out here to Dallas, to Southwestern. I chose it because I really wanted to I wanted to work with the residents in those specialties, and I wanted to be held accountable to that level of service and level of excellence. And Southwestern, the OBGYN, internal medicine, surgery, pediatrics programs are all exemplary. So I thought I'd do that. That's back when we did every other night, every other weekend. It was a bit of a butt kicking, but I had no children, and the woman that I was dating at the time was a doctor also. So it worked out well, and got a great education, and immediately came out of that and went to Irving, Texas, where the Dallas Cowboys used to train, and set up my practice and started to work and built made lots of mistakes. I'm kind of the old-fashioned family doc who ran his own business, and so I learned through the School of Hard Knocks, but eventually built a group of 13 doctors. We had a really neat program. I guess probably the defining moment for me, Larry, was in 1996. I was like G.I. Joe family doc and doing everything that I had learned in my residency program. And over the summer, I had 3 patients die. They were all in their 40s. And I remember literally by September having trouble getting out of bed every day because I felt like I was a fraud. Like I was doing what I was taught to do, and people that were young were dying. And I was just, literally having trouble getting out of bed to go to work. And I went back and looked at those patients' charts, and what I found was all 3 of them definitely had risk. There was a person with type 1 diabetes who had a hemoglobin A1C that was elevated, but every time I tried to get her to increase her insulin, she wouldn't do it because she was afraid of hypoglycemia. Back then, it was challenging to manage things well. We were trying to use insulin, formulations that like R and stuff. So anyway, enough of that. But she ended up having a cardiac arrest in the middle of one night and died. I had a young man who was a good friend of mine, probably my best friend at the time. We were doing all sorts of fun stuff outside of the office, but he had metabolic syndrome, which at the time we didn't really understand. And he had a cardiac event and died. And then I had a woman who was relatively, didn't look like she was at that high risk, but she smoked cigarettes and she had a strong family history of heart disease, and she had familial mixed hyperlipidemia. She went out to Colorado and was on a hike with her family when she grabbed her chest and fell over, and she never made it off the mountain. So it was like, well, there were definite signs of risk, but on every one of their progress notes, I had written, would recommend, a statin for the cholesterol, would recommend, increasing insulin, would recommend weight loss, and, a statin for the metabolic syndrome with an elevated LDL. And all of them said, but Dr. Conard, quote, "I feel fine." And you know what? They did until they didn't, and it was too late. And so in a flash, I am a risk management specialist. I am not a symptom management specialist. And so in that moment, we converted the practice from a, how do you feel? What's going on in your life? Come see me when you're sick kind of model, which back then, tended to be much more prominent in medicine, to a, let me help you age well. We need to manage your risk. And we changed our logo, or, kind of our mission statement, to adding years to your life and life to your years by empowering you to take control of your health. And it was a huge mind shift for me. I know I'm kind of rambling here a minute, but let me just finish this last point. It was a very significant shift in my mentality, because what happened was I went from feeling like I was responsible for my patient's health to realizing I don't eat for them, I don't sleep for them, I don't exercise for them, I don't take medicine for them, I don't get cancer screening for them, I don't come to the doctor for them, I don't manage stress for them. The only person that's going to determine how long and how well they live is them. And all I can do is be a trusted resource and really try to touch, move, and inspire them to think of their health and well-being a different way. And so that was the clinic that we built, and man, we took off like our growth was, we added a new doctor every 9 months once we really articulated who we wanted to be in their lives. And we didn't try to do it for them. We gave them responsibility and held them accountable, which was a different model at the time.
So I'm curious, how did you hold them accountable?
Well, different people do it differently, and this is where it truly is the practice of medicine, the art of medicine. So for me, I wrote a book called The 7 Numbers That Will Save Your Life, and we used it in the practice. I would hand it to people and say, hey, you have 3 numbers that are wrong. I need you to read chapter 2, chapter 5, and chapter 7, whatever, you get the idea. And so they would read the book, and they would figure out that they were not in the numbers weren't what they wanted to be. I got tired of sitting there trying to explain that again and again and again and again. So I just gave the book to them. And they'd come back 2 weeks later, we'd have a conversation. I'd say, how long and how well you live is going to depend on these numbers. This is your report card, and I need you to take these medicines. And if they said no, I'd say, okay, well, then I need you to basically sign a contract with me that says in 3 months, if you don't get these numbers down, then you'll take medicine then. And then you can earn your way off the medicine, because it's really cardiometabolic risk is what we're talking about. And you can earn your way off the medicine because, taking medicine doesn't mean you're dependent on it the rest of your life. And so and that was kind of the way it started. And then for me, I had a rule that if I worked with a person for 2 years and they didn't get their numbers to goal, I wasn't the right doctor for them. So at 2 years, if they hadn't gotten to goal, then I would just say, hey, I don't think I'm the right doctor for you. I'd like to give you the name of 3 doctors and have you go, consider going to a different doctor, because I've been here before. I've been in the situation where people had numbers that weren't a goal, and they weren't correcting them. They weren't doing the things necessary, and they died. And I don't have a heart. I can't go to bed at night knowing that there's people who are at risk of dying of sudden cardiac death and other things. And the problem is really my ability to touch, move, and inspire them, to have them, or you in this case, if I was talking to them, do the things that are necessary. So let's see if we can find somebody who could communicate with you in a way that will, get you going, because, I get you feel okay, but, kind of frankly, Scarlett, it's not about how you feel, it's about your risk. And so that was that shocked a lot of people, right? They weren't really prepared for that, but they made 2 choices. They either said, oh, no, I'll do what it takes. Or they said, I don't want to do anything. And I'd say, okay, here are the name of 3 doctors. I'll get your records to them. And so for me, it was very much about, I didn't want to work. I wasn't going to babysit people while they died. I was going to, I only have so many hours in a day, and I only have so many people I can take care of. And so I really want to work with people who want to live a long and wonderful life. And what often happened is they would kind of say, well, I'm just too busy. I just can't do it. I can't change things. I don't have the time, or I don't have the energy, whatever. And they would leave the practice, but as soon as their friend fell over dead on the golf course, or they had somebody that they knew have a big heart attack, man, they came screaming back in my office going, I'll do whatever you say. And often we are still great friends to this day because they did, and it made a big difference.
So tell me about this practice. So that's sort of the driving philosophy of care behind things. Describe what the practice was like. Describe the network that you built.
Okay, so kind of the name of this, and I'm sorry to have gone on so long with that story, but I think it does set it up, because what I stumbled into at the time was something that we don't have in the United States that I think we need. So kind of the title for this recording there, Dave. I request Larry be something around building the next generation, or the next generation of primary care practices, or something like that. Because what happened was that the president of a medical group that had 182 offices, 343 doctors, wife was a patient at the clinic, and she would go home and tell him about how different the clinic was and how our attitude was so weird. And like, we had a diabetes education program, we had a weight loss program, we had literally had a gym that we had 17,000 square feet. And so we had a chiropractor / preventive musculoskeletal specialist. He was just a great guy who was, did quote unquote physical therapy, did myofascial work, myofascial release, as well as kind of the traditional physical therapy. And his formal training was chiropractic care. But in my practice, he was operating more as a musculoskeletal expert. And it really wasn't about adjustments, although, occasionally I did that too. But anyway, net is that we were putting the infrastructure around people to support them. And, if I wouldn't just say, hey, you need to lose weight and get in shape, I'd say, all right, we've got a dietitian, here's her name, here's the appointment, need you to go see her. On the physical side, here's, the name of the person I want you to see. And I use delegated authority, and we build those as 99213 visits, generally speaking. And so his wife had been a patient, and he had been talking about me for years. So one day I walked in the exam room, basically. It didn't quite happen this way, but you get the idea. And he said, I'd like to talk to you about bringing this practice to 182 other offices. And I was really highly complimented and really felt honored. And so what happened was that I sold everything that I'd created to that company, and we started taking that mission, if you will, and offering it to the other doctors. Now, we wouldn't force anybody to do anything, but we'd say, hey, this is what a practice looks like that is a risk management, kind of center. And it's a little different way of thinking. Would you like to be a part of it? And most of the time, the doctor's like, man, I'm so busy. I just am doing what I'm doing. Please don't give me something else to do. So what I learned really quickly was that we as physicians do what we do really well, and particularly family docs, because we were 70% primary care. And we just are really good at what we do, and we become really competent. We have a special relationship with people. And the practice of medicine today is a slogging, and we're asked to do a bunch of garbage that we shouldn't. I use the term shouldn't loosely because, we're all responsible for ourselves, but that we don't have to do to be, to really live a great life. So as a doctor. So what I did as the Chief Medical and Strategy Officer, which was my title, was I started dismantling the primary care doctor's office. And the two people, Clay and Carl, that had actually developed this whole thing already had this philosophy, because what they did is they said, let's take everything out of the office, off the office that we can, and let the doctor be the doctor and take all the administrative and legal and compliance and negotiating and, all of the garbage that goes along with running a practice. Let's take that off the doctor and let's simplify their lives and let's have them be empowered. So what happened was that, within 18 months of joining the practice, and we got better and better at this. It was a little rough, at times because we were growing so quickly. But what happened is that, all the systems for billing, collecting, compliance, communications, all of those things we brought all the systems to the office, but the doctor continued to own their practice. So it was a model where they would sign up, we'd bill as one tax ID number, all of the infrastructure support was brought there for the doctor, and then they didn't have to worry about any of that stuff anymore because it was managed. And then once a month they got comprehensive reporting that we went over with them, and then they could make decisions about their practice. So if they wanted another MA, or they wanted to move to a different place or bigger office, or they wanted to put marble in the lobby, whatever, they could do whatever they wanted to. But the way it worked was that a dollar came in, there was a billing fee that came off of that dollar, and there was a management fee that came off the dollar. And then everything else that was left went to the doctor's office, which paid for his nurse and paid for the expenses. And then everything that was left went to the doctor. And so it was a fascinating little experiment to see how, when the practice was first brought into the system, often doctors would say, well, I want to do this, I want to do that, I want to do the other thing. They do it. There's a financial consequence, and they're like, I don't want to do that anymore. I should have listened when you said that was going to be a bad idea. And we had a really effective team that was managing, called directors of operations. They managed regions, but it was a physician empowerment exercise more than anything else. And I don't see that in the marketplace today. I mean, there are some vendors out there that will do things like the risk management contracting, and they will support you and your Medicare risk or commercial risk contracts, but they don't support the running of the office. And so I'm a member of a group that's similar to that, where they have really neat infrastructure to do diabetes education and to manage referrals and to help select doctors, et cetera, et cetera, et cetera. But the doctor, like, I'm in that group, I run my own office, I pay my own bills, I do all of that. So there's no economy of scale, there's no negotiating as a team. It's just a bunch of independent doctors who are using a shared infrastructure to manage risk more effectively. And so it was very sad to me when in 2010, I know it's a couple of days ago, but in 2010, that was bought by a hospital that went away from that model and went to a pure employment model, and changed the culture, changed the attitude, changed the freedom of the physicians, changed their ability to make decisions for themselves, because they were no longer at financial risk, which means it's kind of like a fully insured company. You pay a premium every month, and if you don't spend the money, you don't get to keep it. It just goes to the insurance company. So the difference between that and the self-insured, whereas if you manage the risk of your population well, the corporation, you actually get to keep the money that you didn't spend because people are healthier. So in the same simile, the model shifted from, if the doctor, ran things well and made a big influence by caring for a number of people, they don't get paid any more than if they really, there are RVU and bonuses and stuff, but it's a very different way of thinking. And I think that it's sad, because I think that there'll be a future group in America where they bring together the shared infrastructure, they empower the doctors get to make, decisions about their practice. And one of the biggest things that we did with this, Larry, was we took all the population health management services and created a central place that would act as the doctor's office. So in other words, if they had a patient who had hypertension, diabetes, their prescriptions had run out, they hadn't gotten them refilled, or they had heart failure and it was time for them to come in and they hadn't come in most doctor's offices, those patients get lost because nobody's actively managing the population.
Right.
But in our group, even in a fee-for-service environment, we had a whole team that was reaching out and saying, hey, this is Dr. Conard's office. He's missing you. He really wants to see you. And we're really concerned about the fact that your medications have run out and things. Are we still your doctor's office? Can we support you? Can we get you in months medicine and get you an appointment? Or, now it'd probably be, we could start off with a video appointment right then and really get brisk with our care. But in the old model, back in the first decade of the 21st century, we'd get them an appointment, get it set up, get them in. So it ended up generating a much more interactive, much more consistent, much more profitable model for the doctor. And the average doctor increased their income by 30 to 40% at 18 months. When they joined us, they were working less. Most of them took another half day off because they had a lot of other ways to generate revenue, because we were big enough that, like the laboratory testing, we it was like the old days where we would order and we would actually make a profit on labs, whereas now most doctors make nothing on labs. But, I get that could be a negative incentive. It could be that people would gouge that. But the net for our group was because of the infrastructure that was put in place around the population health. And then we also took everything off of doctors they didn't need to do, like the diabetes education and, the diabetes, even management with the insulin protocols and stuff like that. As well as, I could go on about congestive heart failure, AFib, other things. Anything that had a protocol, we set up care teams that would manage everything that didn't require a doctor to make a decision. So anything that if this happens, then that, if this, then that, all the HEDIS, STAR, NCQA, BTE, all of those things, we set up the infrastructure to have that done for the doctor, took it off of them so they didn't have to worry about it. And yet they got awarded all these awards of BTE and things like that. So, I really think the philosophy of effectively managed group practice is to take things off of the doctor. It's not to give the doctor more to do, and let the doctor do what the doctor does well. And let's not bog them down with a bunch of garbage. And I'm so sad to see the burnout that we see in primary care right now. And the problem is that the alternatives for a doctor are to take all the risk, which is, basically stay independent, or to become an employee of a healthcare institute often, and whether that's Optum or regional hospital system. What's missing for me is that middle practice that was such a great honor. I served at the pleasure of the doctors. I worked for the doctors, and my job was to make their lives better in terms of their professional lives, their financial lives, their administrative burden lives, and yet at the same time to create systems that elevated the level of care. And we were $17 per member per month less expensive than the other primary care doctors in North Texas in general. So we were really high performers in terms of keeping people well and not having them get sick.
So if I can follow up on that, can you share or describe any metrics that would speak to the outcomes for people in terms of, chronic disease reduction or disease reversal or anything like that?
Yeah. So, there's different levels of that we could talk about. Probably the easiest one that most docs that listen to this would be able to relate to. Our goal was to have over 80% of people with, diabetes with their hemoglobin A1C less. Back then it was less than 7. Was our goal, really 6.5. So we were aiming at. to get the eye test done, the urine microalbum's what we, would do for kidney screening, wellness exams. Everything was 80%. Our goal was 80%, even on colonoscopies, which is a real challenge because, who wants to have a 6'2" shoved up your backside? But, and we would, and kind of, that was like not the doctor's responsibility though. That was the system's responsibility. That was the team-based care responsibility, because those things are as much about health literacy, education, the person understanding why they would ever want to do those things and what the benefit would be to them than it was, and of course, doctor plays a special part in that by saying, I really think you should get this. And when the person says why, then they need to be able to hand that off and have videos and coaches or counselors be able to talk to people, or nurses be able to explain it. They don't need to spend 30 minutes trying to educate somebody about what is a bone densitometry or what is a colonoscopy and all that kind of stuff. And we were proactively outreaching to those people. So we had people that acted as the doctor's staff, proactively outreaching and raising the health literacy so people got that done. We know there's always going to be 15% of the world that's curmudgeons that just no means no and get away from me, even though I could die of something that I could have prevented. So we didn't try to get to 100%, but we really felt that we could get to 80%, and that was a big part of, when you do that. One of the metrics I used to watch was the percent of people that were diagnosed in stage 3 or stage 4 cancer, and go back once I had someone who was diagnosed with a stage 3 colon, prostate, breast, cervical, lung cancer. We'd go back and kind of run a medical grand rounds or do an autopsy on them, on the diagnosis anyway, and see if we had missed it, if something about the system had failed. And we would find people who just joined the practice who were diagnosed with that. We couldn't have done anything about that. But then we find other people who had been in the practice for 4, 5, 6, 7 years, and they were coming down with stage 3, 4 screenable cancer. And, that's a bad feeling. I mean, most doctors don't really think through it that way. They don't really take responsibility for the fact that, oh crap, we could have prevented that, because they don't know about it often. I mean, the person ends up in a specialist office maybe, and then they die, or, their cancer spreads and they get pulled out of the primary care doc's office for all of that. So many doctors lose their patients when they're diagnosed with advanced disease, and they don't go back and do that process. So, for my mission of being a primary care doctor and adding years to the life and life to the years of people, those were important questions to answer. And that was just all part of the standard reporting that we would go in and share with them monthly. It is not a shame blame game though. You got to understand, this wasn't a, what are you doing? Your numbers are too low. This was a, all right, so we tried this strategy, we tried that strategy, it's not working very well. We're going to go with strategy C, which is we'd like you to record a message, doctor, in your voice, and let's try to share that with your population and see if maybe that would work. Or let's do are you open to Saturday morning inviting all your patients that need something done, and you do an educational seminar or whatever, it doesn't matter. It's whatever the doctor really would like to do and came up with. Not very many of them ever wanted to do a Saturday morning anything, it's understandable. But again, we would, it was their practice. It was their life goal. And our job was to provide the infrastructure to help them realize that. And in doing that, it made a huge difference. It made a huge difference to them and to their patients.
So one of the issues that Barbara Starfield identified was the issue of access. And my experience, when you get into bigger systems, the whole after-hours call access becomes nurse triage and difficult for the patient to get to their doctor. How did you address those issues?
Yeah, so we did a lot of work on it. I mean, the thing is that I probably have a different philosophy than many people do in thinking about that. Because if you do the after-hours telephone call autopsy, what is it, right? I mean, what are you getting with that? Well, what you're getting is someone was handing a prescription that was wrong, or that they didn't understand, and they went home and they want to call back and figure out what was that? What was I? Why am I taking this? What does the medicine mean? Well, that's that was a lack of communication, or they go and it was written out incorrectly. Now today we've got the EMR, but I'll be really honest with you. When you really look at the after-hours calls, there are a lot of people who want to change their appointments. There are one people who didn't understand something that they were told. And then there's a small subset of actual ill people who need help. So, for us, once we did that, there were certain offices that abused things. They were going too fast. They didn't explain things well. They didn't, and they had people who were leaving and were confused, and we were getting a lot of after-hours calls. That's a matter of thinking it through a little better at an office level. And then we had other practices where we got very, very few calls because they did a really great job at that, and the calls they got were really important and they were clinically relevant. And so we set up a triage, kind of a system, but the system was to figure out, I want to change my appointment. I have a clinical question, but it's not pressing person, or do you actually have a clinical need? And for the clinical need, again, I worked at the pleasure of the doctor. Each doctor got to choose how they did that. And what they would do is usually they'd form a group of 5 or so people that would be in a call group together, and they would agree to cover a call for each other. And if it was one of those latter calls, then they would cover for each other. And it was every 5th night, every 5th weekend, and they thought that was reasonable. So, in this case, the doctors are managing their commitment to their patient in terms of service. And our job was to provide the tools, infrastructure, and support to make sure that they were able to do that in a way that was consistent with their wishes. Now, some of them didn't want to ever be bothered at night, and they wanted to sign up for a, kind of an after-hours service. And that service, again, we triaged the people out that just had a question, and the people who actually did need to be cared for more acutely, or with a significant medical problem, they would hire an on-call service that had either a nurse practitioner or a doctor to cover that. And we had those options. They had to pay for it, but we had those options available also. So, I think that was then. So let me answer your question in 2020 as a doctor who still sees and runs clinics and sees patients. I think the next move in medicine is taking medicine to the people. I mean, we're in the middle of the COVID epidemic right now, and we're recording this. And of course, telemedicine has just shot forward 10 years in its utilization. I believe the future of healthcare is going to be taking medicine to the people. And what I mean by that is we now have the ability to do the data analytics, to risk stratification. We can look at what's going on with people, and we can figure out what they need from a chronic disease standpoint, a preventive standpoint, and should anything happen to them, where it would best serve them to get their care, whether that's calling their doctor in the middle of the night, going to the acute center that's at such and such an address, or going to the following emergency room if it's a heart attack or something real here. So that anticipatory guidance, is an important aspect of it also. So where I see medicine going in the future is I, as a doctor, will have a number of people, depending on my age, how hard I want to work, and what I want my practice to look like. It could be anywhere from 300 to 1,300, 1,500, maybe even 2,000, depending on, kind of the age and acuity of them. I mean, if they're all 20 years old, I probably could take care of a couple thousand pretty easily. And then we will have systems and tools that are just are reaching out. That people will come in for a 1-year annual physical or a 2-year annual physical, depending on their age and gender. And then we'll make a 2-year plan. That 2-year plan will have the blood work is at the following time, coming back to see me is at the following time, and get your blood work before. But if you get your blood work and it's normal, we're going to do a video medicine visit where we'll just touch bases and make sure you're okay. And it's going to become much more nimble, much more proactive, much more available, just in time, just in place. And I see a future where the primary care doc is going to be the captain of the ship, called these are the people that I'm going to reach an agreement to have a contract with, basically, to care for them. And I actually think that the fee-for-service way of paying for things is already a dinosaur in primary care. And I'm a huge advocate of a prepaid model. And, if you put prepaid together with risk stratification, then that creates the appropriate payment to the corporation, which I think, or Medicare or Medicaid, and I'm a big fan of a social net for everybody. I believe every American should have primary care. I just believe that access to excellent advanced primary care. So I don't have the exact answer, but I think community centers and other things like that are very, very important. And we need to make sure every person's matched with a primary care doc or a primary care resource team is really what it is. Their data is available. They get proactive outreach. They get supported through their life journey, and they have a choice of whether to engage or not engage. I respect and honor that, but they're not going to die of a cancer that they could have prevented, and the reason they died of it is because they felt fine, and nobody ever had a conversation with them. That is not acceptable. So I see us being at a pivotal point in medicine where the model is going to continue to evolve, and I hope that we get rid of the antiquated, burned out, exhaust the primary care doctor, put them on a treadmill model we've got today, and we go to a team-based, proactive, take medicine to the people model of care. And I very much hope that the marketplace will provide doctors with that opportunity to join that group instead of the butt-kicking independent, try to stay solo as long as you can, or in a small group as long as you can, or sell your soul to a corporation and be told what to do model, which just tends to be the two things we see in America today.
So I've really appreciated an opportunity to hear how your philosophy really drove through your care delivery and your ideas about how to develop a support system, an organizational system that allowed doctors to really deliver the care that they're capable of. I just want to commend you for being that driven by your philosophy of care.
Well, I appreciate you saying that, but of course, I didn't do it. Brandy, I remember, I won't say her last name, but a woman named Brandy that I worked with for a decade was just amazing. And it was her passion. I mean, if I did anything right, it's finding people who were passionate about helping people live great lives and get out of their way. So, I worked with them to articulate a vision, and I helped bring the resources around them. But whether it was Jennifer or Lori or Brandy or Bob or Robert, it was not Scott. I mean, I'm not that competent. I'm just blessed that I have gotten to work with really smart leaders like Clay and Carl when that group was being built, and really great operators like, Brandy, Lori, Jennifer, the people who actually went out and made it all work. But thank you for allowing me to share what we as a team accomplished.
Well, yes, and I did not mean to intend that you were the sole source of that inspiration, but it takes someone in a leadership role who ends up attracting the right kind of people. Tom Collins, in his book Good to Great for the Social Sectors, says the first rule is getting the right people on the bus, and the right people won't get on the bus with the wrong leader, or at least they won't stay with them very long. So building an organization that is driven by a vision that the team gets to be nourished by, nurtured by, and also to feed into, I think that is a critical piece and something that's missing in most of the what I think of is bureaucratic medicine.
Well, I'd have to go back and I'd even take it further, Larry. The hardest part of my entire career development was that when I came out of residency program, I was, I've been told for whatever, 7 years, 4 years of medical school and 3 years of residency, how I was in the top 2% of smartest people who ever lived. And I was so special and blah, 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 all the garbage that they tell medical students and residents. And you know, I was under the kind of the take the hill, be at the front, leadership style. I wasn't, you know, as Jim Collins talks about in his book, you really want the person who gives everybody else credit. You want the person who's leading from behind, who's leading through empowerment. I will tell you that was a very tough lesson for me to learn, and it was not the model I came out of my medical training with. The other thing I'd have to say about the people who I worked with, they were courageous, they were strong-willed, and they wouldn't let me have that kind of personality. And you know, Carl and Clay and a woman named Susan Aran, who I wrote a book with called The Art of Medical Leadership, where I describe a lot of the things that we've talked about in that book. You know, Susan, the reason I knew Susan Aran is because they hired me as a professional coach to help me make that transition from a more autocratic, aggressive leader to a, you know, lead from behind, empower your team type leader. And that took 4 years. It took from 26 to 2010. I think a big missing is that education. And that's why when our group blew up and basically was destroyed by the new philosophy of the hospital that acquired us, we wrote the book, is because we felt like so much learning had occurred in Carl and Clay's 16 years since they had established the group, that we wanted to try to capture some of the lessons and be able to share that, so that if other people wanted to build a group like this, to build a group with the leaders that were leading from behind, that empowered people, that worked, really served at the pleasure of the employees, and with a very strong mission orientation, kind of a conscious capitalism philosophy, that would not be completely lost. And so I think medical education should look in the mirror and ask, are we really growing, designing, and implementing leaders that can have that kind of leadership, or are we're still stuck in the 19th, 20th century, autocratic, if I want you to do something, I'll tell you what it is. If you want to know what to think, I'll tell you what that is, which is just really a dysfunctional remnant of the past that we still see a lot in medicine.
Yes. Well, Dr. Conard, I want to thank you very much for spending time with me today. And just for the folks who might be listening in, I've had the pleasure of reading the books that he's mentioned, and actually a couple more that he's written that he hasn't mentioned. And I would highly recommend all of them to those who are listening in, be you medical students, residents, practicing docs, or people who work with within medical practices. I think you've made a real contribution there. Thank you.
Thank you, Larry. And for those who are listening, I'm kind of in the autumn of my life. I think I've got about 12 to 20 years left. I often think about, man, why not just go start another example of that model that I would just kind of walk through, where you really empower, lift people up, and give primary care doctors a new lease on life that they may not have access to. And, to be frank, it is a lot of work. But if there's anybody out there who wants to do that or has done that and would like people like Susan and myself who are part of that effort to share our experiences, please consider me at your disposal.
Great. Dr. Conard, thank you very much. Let's bring things to closure.
All right. Thank you, Larry. It's such an honor. What you do for the medical community is so unheralded, and nobody appreciates it. But those of us who are in primary care really understand and appreciate your tremendous role in bringing us together, keeping the conversation going, supporting us in policy and the national conversation. So thank you for all you do.
Oh, it's my pleasure. Thank you very much. Take care.
All right. Bye-bye.